Dear Professor Sarkozy, dear Professor Kem, ladies and gentlemen, first of all, I would like to thank the organizers for the invitation to join this session. It's certainly a great honor and pleasure. However, the task as was assigned is not an easy one, because electrocardiography of ischemia is a topic which is studied and discussed for more than a century. So I doubt that I really can show you here new tips and tricks which would surprise you. But let me start with a very common clinical situation. And this is a patient with atrial fibrillation, with very prominent ST segment depressions. And this is very frequently the reason why these patients are referred for coronary angiography, and the result is in more than 80% negative. At least there is nothing treatable by interventional therapy. If you look at this another patient, 46 years old man, and you see that the ST depressions are more prominent in those beats which have a shorter RR interval. This is something which is very common, but the positive predictive value is relatively poor. However, the negative predictive value is very high. What do the recent guidelines from yesterday say about this situation? This is the bottom line. Using ST segment deviations during supraventricular tachyarrhythmias are not a reliable evidence of obstructive coronary artery disease. It's especially true for atrioventricular tachycardias. But I would like to focus on the most actionable ECG diagnosis of ischemia, and this is to diagnose precisely coronary artery occlusion. We have, of course, also here guidelines from last year. In the right corner, you see the updated version of the criteria for ST segment elevations. And you see we have different criteria for younger men, for older men. Women of all ages have the same. And if you see an ECG like here, everything is clear, and these patients needs to be transferred to the cath lab as soon as possible. However, it turned out that the elevations of the ST segments are not really a very good predictor of myocardial area at risk. And in the 18s, when the authors looked at the number of leads with ST segment elevations or the sum of ST elevations, the predictor of region at risk was relatively poor. Even more, if you look at the right side of the diagram, you see that the only curve which goes down is the curve which represents the sum of ST segments. It shows that the more transmural the infarction develops, the less predictive is it for the area at risk. So there is a clear gap between STEMI criteria and occlusion of coronary artery. And this is called now occlusion myocardial infarction. And as you can see, even if we apply computer criteria for this occlusion myocardial infarction, the sensitivity is relatively poor, a positive predictive value 54%, negative 96%. An experienced cardiologist is a little bit better. Now, the word Bayesian became, unfortunately, well known in the last days because of the tragedy of this super yacht, and became also introduced to the non-scientific community. But in electrocardiography, I believe it is very important to adapt a kind of Bayesian reasoning. This means that we should use a certain hypothesis with a pre-test probability, but we should upgrade it slowly and complement during the process of during the pathway of our diagnosis. And in STEMI, of course, this paradigm that the disease, that means occlusion, is defined and named after only one element, this is ST elevation, without regarding the other parts of the ECG curve. This is even a very imperfect test. So we have to realize that in acute coronary syndromes, ECG changes are very dynamic. And you see in the upper row the transition from normal to hyperacute T wave within minutes or hours, when typical ST elevation, and again then a slow decrease in the ST elevation and creating Q waves. This is a ECG taken from a paper by Professor Williamski from his Prague study, where he has shown that this patient in the pre-hospital ECG had a clear ST segment elevation, received heparin, received aspirin, received clopidogrel, and less than 1 hour later in the cath lab, the ECG was normal and the angiogram was also normal. But this is a very rare situation. In his experience, only around 3%. So to diagnose STEMI reliably is a very complex ECG endeavor. Why? Because we have to take into consideration several aspects. There's minimal ST elevations or less obvious ST elevation. We have to look at ST depression, their location, number of reads, and the treatment. We have hyperacute or so-called bulky T waves. We have STT morphology. We have to look at the entire QRS complex and look at the QRS distortion or associated Q waves. We have to look, this is very important, to the proportionality of STT changes to QRS amplitude. And then certainly we have also a situation with intraventricular conduction disturbances, LBB, pace rhythm, and we have, of course, pseudo-STEMI mimicking patterns like benign early repolarization. So this is a simplified diagram of some changes we should always have in mind when we try to exclude occlusive myocardial infarction. These are hyperacute T waves. This is the so-called the winter T wave, in spite of the fact that it was first described by Dressler in 1947. And you see the posterior occlusive myocardial infarction with depressions, and you see the modified Scarboza criteria, which look at ST segment and QRS complex relations in patients with left bundle branch block. Now these are according to one of the latest documents from the American College of Cardiology, these are the STEMI equivalents. And if you just look at this list of criteria, which are not new, they are known for most of them more than 20 years. But if we cannot apply them in real life, this means they are not sustainable. Couple of ECG, hyperacute T waves and subtle ST elevations. Most of them are LAD occlusions, but here I would like to underline the feature that normally the T wave amplitude is not higher than the QRS complex. But here in this situation, even with very modest ST elevations, you have a much higher T wave as the amplitude of the QRS complex. What does it mean? It means that the electrical force of the ventricular myocardium loses its strength. The QRS decreases and ST segment increases. So this is something to always bear in mind. These are the criteria for left bundle branch block and myocardial infarction. Here you see concordant ST segment elevations, concordant ST segment depressions, and discordant ST segment elevation. Again, important is the ST to S ratio. The smaller the S, the higher the probability that this represents a myocardial infarction. Early repolarization is something we see very often in younger people. And here there is maybe one trick I could show you here, is that there is a visual assessment of a formula for anterior STEMI, which looks at 4 parameters: R wave amplitude in lead V4, QRS amplitude in V2, and the sum of these, from this is deducted the QT interval and ST elevation in V3. And if this is less than 12 millimeter, you have an excellent predictive accuracy for anterior STEMI and not for benign ST elevation. This is a work which was in detail elaborated by Dr. Aslanger, and he developed even a practical trick, old-fashioned electrocardiology, when you make small lines with your pen, and you can make all these calculations which appear difficult but are not. This was about a 71-year-old lady who walked in for chest pain and dyspnea, body mass index 42, hypertensive, troponin 1000, ejection fraction 30. Finding distal main stem, 99% stenosis, emergency cabbage. And what you see here are depressions in several precordial leads. You see elevations in AVR, and you see a paradoxical decrease of S amplitude in lead V2 compared to lead V1. This is a sign of very large myocardial infarction, and this is also in these recommendations from the scientific societies. This is again a case showing a 62-year-old gentleman who was wakened up by stabbing pain at 1 in the morning. He had a family history of CAD. He was on statins. He received 300 milligrams aspirin and morphine. And what you see here are mainly, what is evident, are the depressions in 2-3 AVF. But what is less evident is how the lead V2 looks like. And 65 minutes later, he arrived in the cath lab, and this was already a clear STEMI, but the early warning signs were missed in this particular patient. What was the basis for that? This was acute occlusion of the proximal LAD. There was primary stenting, thrombus aspiration, and the flow was restored. Now, this session is called Cardiology Toolbox. So let me think about the tool. What do these 2 ECGs of 2 patients with chest pain have in common? The upper one is clear. This is an inferior myocardial infarction. The lower one is less clear. But if you look at the angiographies, you see that both of them have total occlusion of the circumflex artery. Could artificial intelligence be of help here? Well, a deep neural network was developed on the basis of almost 20,000 patients, and technically it was solved by taking a photo from the ECG. The ECG can look like this, typical for emergency situations, and the algorithm extracts a digital ECG waveform, and this waveform is further analyzed. And what this algorithm says is that yes, this is a occlusive myocardial infarction with high probability, but it also teaches us, it's not a black box, it teaches us the dark blue areas are those areas which were most decisive for the algorithm to make that particular decision. If you see here, you is, for instance, of course, 2, 3, and 2 ST elevations here. If we would use this algorithm in these patients, from the first ECG, from the ambulance, it would be clear it's an occlusive myocardial infarction. The hyperacute T waves, you see it very clearly here, that especially if we have a reference ECG from that particular patient, you can clearly see what happened here is the T wave increased, and the QRS amplitude decreased. Oh, sorry. What are bulky T waves? These are the hyperacute T waves. Usually the area under the T wave is much higher as the absolute QRS amplitude. However, this is difficult to do in real life, so we need a tool for that, and it appears that artificial intelligence might be a suitable tool for that. Have a look. I think this is my last ECG, 60-year-old woman. This is taken from the database of Dr. Smith, a recent patient, epigastric and right upper quadrant pain. You would probably think about gallbladder. This, you see already here that the V2 has a particular appearance. However, the decision was not made for a myocardial infarction, but the wise decision was to make a second ECG in 10 minutes. And here we see again already the progression of the changes. And if you compare the first one, for instance, in V5, you see also a significant decrease in QRS amplitude besides the ST segment elevations. So this algorithm could help us to identify it properly. This is the ECG number 3, which is clearly an evolved ST myocardial infarction. And we have tested this in a test of cohort of more than 2,000 patients. And what came out here, that this occlusive myocardial infarction artificial intelligence model can achieve remarkable precision. The area under the curve in detecting occlusion was 0.94. And this is my last slide, ladies and gentlemen. So Willem Einthoven meet Thomas Lewis, the founder of modern cardiology, 103 years ago. They are in good mood, and I think because they are expecting artificial intelligence assisted electrocardiology. Thank you very much.
Thank you very much, Robert. I think I derived from your talk the notion that single ECGs are not as good as multiple ECGs. Single deviations on any particular electrocardiogram are not as good as multiple deviations. And that artificial intelligence is better than we are at dealing with the electrocardiogram. So my question is, why does the AI machine want to teach you how to do it and put itself out of business?
Yeah, this is exactly what I wanted to also show with these so-called heat maps. These are the maps with the blue areas which mark the segments of the ECG that were important for the particular decision. And I think this is a very, I would say, appreciated feature of artificial intelligence, that it should not behave like a black box. It did something, it made a decision, but we don't know why. So it should be a transparent tool. I think if we can achieve this, this will be also a breakthrough for the artificial intelligence, because it will also teach us. And I have tried to show our audience very precisely that, of course, as was seen also there, with one single lead doesn't make the diagnosis. This is also part of the Bayesian thinking.
Thank you.